All right. Hey everyone, I'm Jonathan, fourth year med student at ICU. Going into anesthesia, had a stroke code there, had a few in the hospital, and thought it was something we could all talk about today. So, yeah. And please feel free to interrupt me and ask questions. I'll do my best to answer. So the first thing is just why should you care about my talk? So a good amount of strokes happen in the hospital, like 4 to 17%. There it complicates a decent amount of admissions, and these all seem like small percentages, but considering how many patients we see, it's definitely bound to happen. And I've been doing this for a year, and I've had a few stroke codes already. It costs a lot of money, like $5 to $10 billion. All my lecturers put that in their slides, so I figured I'd put it in mine. I don't know if anyone is too concerned with how much that costs. And then the interesting thing that I came across is that it's actually it's actually better if you have a stroke out in the community than if you're in the hospital, which seems very paradoxical to me because timing is everything. So I'm going to talk a little bit about that too. So this is from a study that was exploring exactly that, some of the stats involving why, or showing how it's in the hospital. And it's actually a slower time to get scanning and imaging and longer time to get TPA and whether or not they qualify for TPA, and then whether or not we're managing their lipids, and basically everything's worse at the hospital, which is very interesting to me. But what it says to me is there's room for improvement. That if strokes are happening in the hospital and they're surrounded by people that have been trained, and it's happening, and it's worse than if someone's playing golf, then that's a problem and some room for change. So if you were thinking, well, of course they're worse in the hospital because patients are sicker here, you wouldn't be wrong. Patients have a lot more comorbidities if they're in the hospital. They're in the hospital for some reason. They're already sick for something. They've likely got, hypotension, lots of things going on. Some of the things I highlighted on here was the level of consciousness. So for this first stroke code that I called on a patient, she had CO2 narcosis, and I actually called my senior resident. I was like, yeah, she's not really responding. It's making me really nervous. She's like, oh, her CO2 is really high. That's fine. I was like, no, I think we should come back down. She's like, yeah, I'll go check it out. Then she came down, and she had pronator drift, and we did a neuro exam, and she ended up having a stroke. So it's very difficult to recognize when some of these patients are having a stroke, and I talk about that a little bit throughout the talk. But especially here, when the majority of our patients are on some sort of sedation, or they're just weak and tired and they don't want to move, so seeing their leg not move is not strange for people that aren't having a stroke. But the strokes are worse when they happen in the hospital. There's a CNS scale where the lower number is worse, and the larger majority of them are worse when they happen in the hospital. However, a study did look at that and tried to explore it, and actually they accounted for all the comorbidities, age, gender, basically everything you look at that you think would cause a risk, and they actually still found it's worse to have a stroke in the hospital. So clearly there's some room for improvement if they're accounting for all these factors. And then I just put up this is a little headline from just it was one of the things that can come up on Comcast, where you just see the headlines kind of go across. This is what people not in the medical field see, is they just see this headline that says, better for you to have a stroke while you're golfing than actually in the hospital, and they kind of references some of these other studies, and that's would make me nervous. I mean, it still does. So why the gap? So a study broke it down into 5 major things. I'll spend a little bit of time talking through each one. So the first one is the difficulty in recognition. So I already mentioned some of the things. If they're sedated, if they just don't move a whole lot, if they, have a mask on, if there's something, it's really hard to recognize some of the symptoms of the stroke. And also, a lot of things we can kind of convince ourselves that it's something else we're doing. It's, that medication makes people sleepy. They just got some Benadryl, or they, narcosis would be a big one here, too high CO2. And also, if different units, different hospitals, obviously ICU, we're watching everything, but on surgery units, they're just worried about the wound, so that's kind of all they're concerned about, and they go in, look at the wound, and they don't really, do the other kind of parts of the exam, so they can miss strokes that way. The second part kind of goes hand in hand, so they said they defined it as delay between symptom onset and symptom recognition by the staff, and I'll talk a little about this later, but it's kind of, there can be a familiarity you have with your patients where you kind of just think that, oh, they haven't moved a lot. So you may not notice that they're actually not moving their left arm at all, as opposed to just less than normal. And also some of the kind of dot phrases and bedside exam things we say when it says moving all 4 limbs spontaneously in the neuro exam. That's really important to actually see all 4 limbs move, and kind of the bedside or doorway physical exam, some people call it. It doesn't happen in ICU, but in other units where you just kind of look in, oh yeah, they're looking all right, they're sleeping. You can easily miss some symptoms there. And then the delay of the initial eval. So a lot of this was just exploring how it's just not something that people look for on certain floors. Again, I don't think this applies to us as much on the ICU, but on surgery floors, other floors, they're just not, stroke's not kind of constantly on their mind as something that they should be on the for and might not know what to do about it, which is what we're going to talk about here. And they also just mentioned like the distance to get to a scanner. So obviously, like in the emergency department, the scanner's right there, and they've got lots of things in place to like get you in the scanner right away, no matter what. Here, it's can we get the patient down? I don't know what the exact protocols are at this hospital, but I know there can be some confusion with, okay, like do I bring the patient down? Do we need transport? Does a respiratory therapist or CRNA need to be with them? Who needs to kind of make sure that they're safe? And there can be some delays in that timing. Last one, the fourth one was the poor adherence to consensus measures, which really is just a fancy term for saying that if you're in the hospital, things can get really jumbled. Order sets can get really complicated. A lot of things have stroke order sets, and they make you pick through certain things that can make it a little more difficult. Again, in the ED and strokes that come in from the community, they often kind of, it's almost automatic what they do for a stroke, as opposed to in the hospital, where it's do you have to get neurology involved before you call it? There's just lots of things that can go wrong. And that kind of goes with the last one, with the transitions of care. So this actually more involves with after the stroke happens. So, for example, if a stroke happens on a surgery floor, does neurology become their primary? Do they just consult? Do they curbside? Do they just give the recommendations? Do they take over? There's been lots of instances where they just don't know who's kind of taking the patient now, because we all have different priorities based on what we're worried about is sick. And if a stroke, if they're there for a more routine surgery and a stroke happens, you might think, well, neurology should kind of take over this patient, like they should become a patient for them. However, that doesn't always happen, and they just note some other parts of confusion. So all the reasons with the gap. So what can be done? So the American Heart Association, the American Stroke Association have just get with the guidelines, or get with it. They tried to do one of those kind of catchy guidelines. And it's a website, and they actually have lots of protocols and things that can help hospitals kind of work through these. So I recommend checking it out. You just like Google get with it, and the website really goes through lots of kind of basic things and basic trainings, and even short 2 to 3 minute videos that can kind of help explain. And then a lot of it's nice to go through like kind of with like a charge nurse or the hospital administrator that kind of says how each thing applies to the hospital, because they know hospitals are different. Here we're different than the U, different than some of the county hospitals. And then one paper that I read that kind of was talking about these differences in strokes. So it kind of talked about all the things that are above my pay grade of like certain protocols and certain like kind of systematic changes they can make. But staff education, I think, is one of the things that can all do better. So that's another part of the reason why I'm giving this talk. And then along with that, so they were talking about staff education. There was one that actually noted a study where they actually did a survey of 115 nurses, and they said over 97% could recognize a stroke, could know the stroke, could know kind of to know to call a stroke code, but past that, it said most just said get a CT, and that was the main concern, which is very correct, but there's kind of a full picture of things that need to be done, so I'm kind of go through that today. So one of the papers I read defined it as the 5 Ds. They had 2 other Ds, like from the community, but I cut those out, so this is my version. So I'm going to talk about 5 main, the 5 Ds of the stroke code and kind of handling a stroke. So detection, dispatch, data, decision, and drugs. So if you can come away with this talk with something, these 5 things will be the things you guys come away with. So the first one's the detection. So as I said, this one, nurses and everyone's really good at recognizing these strokes. The really obvious one, I'd already mentioned some of the difficulties we have with some of our patients that are sedated or have other issues. And then I just put up one of the stroke warning signs. Everyone, I think I remember like even learning in high school the FAST exam, face, arm, speech, and time. So you just note the time down of when you think it's happening. I think we can do a little bit better than that for the general community. So I included the kind of more intense one, which involves the eye movements, the sudden headache, and then the ataxia and things we can notice, the dizziness that maybe aren't as obvious to people not in the medical field. Another part of the detection is looking at the risk factors. So up in the top right corner, I talked about the general public risk factors. So basically anything that makes them a vasculopath, smoking, diabetes, their diet, sedentary lifestyle. We all kind of know these. But then there was a study that looked at people with these conditions, and if they're hospitalized, if there are certain things that make them more likely to have a stroke, they notified these 6: fever, leukocytosis, unstable blood pressure, elevated diastolic, dehydration, and a past history of MI. It puts them at a further increased risk of being hospitalized and having a stroke. So the next D is the dispatch. So this is essentially calling the stroke code. So there is a National Stroke Association has a protocol card. They print them out and they come in little kind of pocket-sized handbooks that can be part of kind of the things we always carry around. Some of the things I highlighted, so basically the timing of the symptom onset. So I'll go into this a little bit later, but when the neurology team shows up for the stroke code, the first question they're going to ask, the med student, the resident, the attending, everyone's going to ask, what was the last known normal? And they're going to keep asking that question because that helps determine what we do next. Other things I know in here is, so it says oxygen saturation above 92%. What I've seen happen in real life is whatever oxygen they're on, especially on their nasal cannulas, turn it all the way up to 10. After I heard them, just give them more oxygen. And then also the other thing is just notifying the charge nurse. I'm not sure if we do it any differently here, but this is what they recommended, was notifying the charge nurse to make sure that just no one's leaving the patient because they're at fall risk. Something could be going on if they're aspirating. There are lots of things that you just don't want to leave a patient alone if they're having a stroke. So call for help, stay by the patient. Then the getting a blood glucose actually helps the neuro team a lot, so that's something we can easily do. And then the last one here is, it said make sure they have access of a 20 gauge. That's what they recommend. I've had the second stroke code I've personally been involved with was after surgery. A patient had a 20 gauge, and the neuro team showed up and said we won't be able to give TPA unless it's an 18 gauge. So I'm not sure what this hospital-specific rules are, but I know that was actually a problem because she was a really tough stick. We had to call down the vascular access guy was running down the hall with his ultrasound because no one could get an 18 gauge in this lady, and that was a big delay that's happened in the past. So they recommend 20. Not sure exactly what has happened, but getting access.
Here's our mix.
Yeah, she's here right now. Yeah, I mean, I don't know if you like running to the hospital. I don't mind it. Yeah. But getting access is huge. And then, the second part is, so obviously a lot of this is fill in the blank because they know it's going to be different for hospitals, but just drawing up, I believe, I've heard the colloquial term is just drawing up a rainbow of blood samples and see if they want to test for anything. If the neuro team finds anything in their history, they do whatever. It's just always good to have blood that you can send to a lab for more information. So this is a pocket card. And then all these resources I have listed, so if anyone wants it, they can let me know. But this is just the pocket stroke protocol card, and it's on the National Stroke Association website. And it just kind of goes through the steps. And a lot of it are fill in the blank because I know it's different for the hospital. So the third D we're on is the data. So this is basically, what does the stroke team want to know? So there's a assessment called the NIH Stroke Scale. And what that is basically it's the neurology team go and it's a thorough neuro exam is essentially what it comes down to. And I broke down some of the parts, and I think this is good to know what's going on because especially if there's family, and I feel like a lot of family would say, please step out of the room, but they're still kind of by the door. So, especially if you're nursing staff or any other staff that's around, I've done this, you can just kind of explain to the family what's going on. Because why are they looking in their eyes? Why are they asking them to read things? It's just, we're just seeing if we can help localize, help the radiologist through the CT, because a lot of this is localization and timing. And then also the patient history. So I know my job when I was on neurology as the med student was if there's a stroke code, you run there, you get on the computer, you start reading about their history, and you figure out everything you can about them as fast as they can and start letting the rest of the team know. So they might be asking lots of questions, so just having their chart up and ready, their meds, and ready to kind of look everything up is important. And then just a few pictures from the stroke scale I thought were interesting to put up here. So the one on the left, patients are asked to describe what they see. So this tests a few things, a few brain functions to kind of show, can they see okay? Can they recognize things? Can they name things? It's also testing for aphasia if they're calling it the right word. Also, there are some patients that will only say things on the right or left, which is called neglect. So that's also localizes to certain parts of the brain. So if they're only saying items on this side, and then that shows that some part of their brain is not working, where they're ignoring the left side of their visual field. And then same with this picture. There's long instructions that I didn't put up on here about kind of what they get credit for. It's supposed to be the kids stealing the cookies and the mom washing the dishes and it's leaking, and they're just supposed to kind of notice these things. I always think these are interesting. So these repeating the sentences test again for kind of a better test for aphasia and seeing if they're picking the right words and if they can read and follow commands. This I always think is interesting because these words are to help test for dysphagia. So sometimes it's tough to hear if they're speaking correctly, especially people that might have a strong accent or you just don't kind of understand. It's difficult to evaluate whether or not they can say words properly. So if you see these words, mama, tip top, 50-50, thanks, huckleberry, and baseball player, if you mouth those words right now to yourself, you kind of have to use lots of different parts of your mouth and your tongue, and kind of really makes it difficult to miss some sort of speech thing if you're using these words, and these words have been studied and that's what they use. So the next D is the decision, so a few slides on that. So obviously the biggest decision is TPA or no TPA, and I'll go into a little bit more about thrombolytics later, but this is just kind of the official guidelines. So the timing of less than 3 hours, that was extended to less than 4.5 hours from the last known normal. Now in Europe and in certain other countries, they're extending it to 6 and 8 hours, where they're trying to test to see if TPA will still be useful and further on. And the biggest contraindications are if they have high blood pressure that can't be controlled with certain medications. Obviously bleeding risk, if it's a hemorrhagic stroke. If everything's kind of getting better, that's also, we don't have to do the TPA. But this is kind of the big decision, is TPA or not TPA. And then more recently, the next decision is thrombectomy or not thrombectomy. So I have a video next to show about kind of how that works, but they actually did 5 trials to see how effective thrombectomy plus TPA was versus TPA alone, and they actually had to stop 2 of the trials early because they were hurting the patients that weren't getting thrombectomies. So that's the first time I've heard a study of them stopping because it's been too helpful. I've heard of studies where they're hurting someone too much, so they have to stop, like hurting the people they're testing with. But this was the people that were being randomized into the TPA alone group. We're not getting the same benefit, so it was unethical to continue. So that's kind of how good thrombectomy is. Up here I put the modified Rankin scale, which is basically an assessment of their kind of abilities in day-to-day. So 0 is they're fine, 6 is kind of totally paralyzed, and then in between there, 1 is like a small hand tremor, something that's not going to affect their day-to-day, but they're not perfectly normal, and it kind of goes up from there. So we see the top is the thrombectomy and the bottom is the control, and just patients were statistically always better when they had the thrombectomy.
Do they do that at the U? I know they do it at South Cal.
We rushed patients to the U from here. They do. I don't know if they do it at South Cal.
I know they do it at South Cal. That's
okay.
right.
Yeah, they do it at the U. Oh yeah.
Okay.
Yep. We've got big
Yeah.
interest in thrombectomy.
So those were the functional outcomes at 90 days. So not right away, but they're seeing long-term kind of how can we get these patients to have a stroke that aren't having a debilitating injury for the rest of their life. So here I have a video. This guy does a good job explaining it. Hopefully everyone can hear it.
That's the coolest thing ever.
You might have to narrate it.
Okay. So here they're just showing the vasculature of the brain. They zeroed in on the MCA, which is the middle cerebral artery. I'm not sure where the sound's coming from. He does a better job explaining it than I can. I'll try.
Give it a go.
So right now they're just explaining that you have a blockage in an artery that's preventing blood flow to parts of the brain. Yeah, he's just talking about how parts of the brain die with a lack of oxygen, so that's why timing is so important. And he's talking about how they normally go in through the femoral artery and go in with a catheter. So this is the catheter that goes up into that vessel. A smaller catheter comes out of it, goes past the clot. So there they have the catheter coming out. And then they put the sheath around it that will eventually release kind of what's actually going to mechanically take out the clot. Yeah, so kind of like a snake you use in plumbing, and they put that past the catheter, and they'll show how they expand it and kind of pull it through the clot. So then they're increasing the pressure and they're kind of breaking it up as much as possible against the wall of the artery. And they're just getting the most of it, as much as they can, broken up and and also just during this time they're allowing blood flow to go past it. So then they do a balloon at the bottom of the artery, and they reverse flow, and now they're essentially pulling out the clot. And they're reversing flow, and they're trying to get everything sucked back, because the major concern with this, and also with carotid endarterectomies, which is where they take out clots in the carotid, is if you break apart a clot, a little piece could fly off, and you don't want that to fly off and go into a vessel you can't reach or cause some kind of further damage because you're defeating the point. So they balloon it off, and they really get suction, and they try to make sure they get as much clot as they can, so they're reversing the blood flow for that short time.
Is that cool or what?
That is awesome. How many years have you been doing that?
Not too many.
I was gonna say, I know it's not too
Less than
many, but
5,
just
huh?
think how they can go into the brain.
Yes, negative. But
Yeah.
it all starts with recognizing. Patient has to be recognized. You can't just trying it out of
They go through the femoral artery?
Yeah.
Here they might do it through the brachial.
Yeah, I've seen one through the brachial. It's kind of whoever's doing it's preference, and if they see an easy access somewhere. So this is a beautiful picture of the scan. So here they show the CT, and that's where they see the stroke. This is where the clot is, and this is after the surgery. And some of the
Not surgery. Endovascular.
endovascular procedure. Okay. So after the procedure, and some of these models I've seen where they can make it 3D, and they can just basically show before and after and what it should look like, and it's pretty incredible what they can do. And it's almost if the clot didn't happen. It's blood flows reduced for a little bit, and we get this timing fast, and then everything kind of flows back normally.
Does this remind you of anything that happened about 20 years ago, 15 years ago? I know it does to me. We used to, when we have somebody have a heart attack, what would we do 20 years ago? Admit them to the intensive care, put them on a monitor. That's all we did. Literally. Just if they had a bad rhythm, shock them. Now we get in there, we intervene. They're putting stents in there, and they're getting clots out. They're dilating coronaries. It's all about saving myocardium. So that's 20 years ago with the heart. Now we're starting in the brain to rescue. So failure to rescue is a problem, and it's a problem for many diseases. And so we don't want to have that failure to rescue.
So if they don't qualify for TPA and thrombectomy, which are much better, it's been proven over and over that we can do it, we should. But if they don't qualify, if they're bleeding, if they have some contraindication, if it's been too long. I know recently they've been exploring where if people wake up with stroke symptoms, they've actually been exploring, because I know in Europe they will accept that within the timeline. Here when I was doing neurology at the VA, they said that some docs will actually go through with it and just kind of go through with the thrombectomy, even though they can't be 100% sure that it's within the last 4.5 hours, but that's something that they're exploring is if you wake up and you have people wake up in the morning with stroke symptoms. So the last one is just kind of anticoagulation and preventing reoccurrence. So after a stroke, we do a pretty extensive workup. So they ultrasound the carotids, they do an echo, Holter monitor, look for weird rhythms. They look to see if they have any other reason for them to be hypercoagulable. Also, some of the more rare ones, posterior reversible encephalopathic syndrome, or PRES. So that can happen in a few conditions. I've seen a patient with really bad multiple system atrophy where their blood pressure was going up and down like crazy and we couldn't control it. So that was one of the things we worked them up for. Temporal artery biopsy, so if they have inflammatory conditions, and then vasculitis, that's also something we can look for to see if we can, a lot of these things we can do something about. It's like the carotid ultrasound. If they have a lot of stenosis, we can do the endarterectomy and take out the clot if little pieces are breaking off and going to the brain. Other than that, a lot of it is just caring as much as we can for the patient and improving their status. So one of it is just making sure they don't get another stroke. So anticoagulation is often discussed if they have reasons to have other clots. We look for DVTs. PT, OT, and speech can work wonders in these patients. A lot of them, if a lot of them get great improvement with these therapies and can go back to near normal. Planning for discharge, making sure they're safe, and then secondary prevention is looking at their lipids. Should they be on a statin? Should they be taking aspirin every day? These are things that a lot of them are done in the outpatient setting, and we just kind of set them up for it, but basically just not making it worse, which is kind of the third decision. And the last one is the drugs. So I first just mention everything that's not TPA, and I'll go into a little bit more TPA. So aspirin is the only antiplatelet drug that's shown any efficacy in the acute stroke. The way that they put it, which I thought was put really nicely, I just want to read it because they worded it so nice in the article. For every 1,000 acute strokes treated with aspirin, 9 non-fatal stroke recurrences will be prevented in the first few weeks, and 13 fewer patients will be dead or dependent at 6 months. So not a large effect, but it definitely helps, so it's worth doing. Some of the other drugs, so they've tried heparin and low molecular weight heparin unfractionated, and it's shown no benefit, and it's actually just increased the bleeding risk. So they have not found any of those anticoagulants to help. So neuroprotective, so there was a thought that if you basically froze these patients, you could decrease their oxygen demand in their brain and save part of their brain if you slowed everything down. They tried this in animals. It worked great. I couldn't really read a lot about it if they've tried it in humans. Sounds like for some other things they've tried, it has not panned out at all. And also along those things like glutamate and other chemicals that can help slow down activity in the brain have worked in animals but haven't shown any promise in humans. And then lastly, so mannitol. So a side effect of some strokes can be swelling around the brain, and mannitol will decrease that. However, you're decreasing perfusion to the brain, and you can cause hypovolemia, and you can make things a lot worse with mannitol. So it is very occasionally used, but there are certain circumstances where neurology can decide that it's worth decreasing the edema at risk of further brain death, parts of the brain dying. So TPA, I just put up a little reminder of this pathway. So it activates plasminogen, which turns into plasmin, which takes fibrin, which is what the clot's made of, and breaks it down into fibrin degradation products. So this is, people mostly know it as a clot buster. We give it intravenously. It goes throughout the whole body, kind of busting everything up. Hopefully in the future, and starting a little bit now, they have TPA where they can give right in the actual clot, so they can get a catheter and just put TPA right where it needs to be locally, so you decrease the risk of bleeding other places. And then the biggest thing with TPA is talking to patients about the risks. I had to do that to a patient a few days ago, talking about the risk and benefits of TPA. One doctor made this diagram, which I think is really helpful, and it can be found online to help explain to patients kind of the risk and benefits of TPA. Because giving a lot of percentages and numbers to a family or a patient that's really concerned or really nervous can just make things a lot stressful. I know I've had to learn that lesson throughout med school, giving a lot of numbers, and then they just clear that they weren't listening and didn't hear. Not their fault that you weren't giving the information in the right way. So this chart. So this is if you give TPA within time. This was when they did it within 3 hours. The dark green patients are patients that went back to totally normal. So this is almost what we look for in the thrombectomy, which is where the brain gets reperfused, the clot gets busted up, things improve. The light green is things are better, but still not back to normal with the TPA. The white is no change. The black little line, the horizontal line, is a bleed. And then the red line is you made the stroke worse, and the dark red is they had a bleed and they died or became severely disabled. So giving a good color diagram I think is really helpful to help just kind of explain the risk. And I thought it was interesting that you can have a bleed but also no other change, so a bleed somewhere else, but they did note that it does increase your risk of bleeding.
It kind of reminds me of a diagram that you take a flight, you can pick a seat, but you can't pick which chair you're going to sit in there.
Yeah.
You see it.
So then what to do during TPA? So the best information I could find was from the company that makes TPA. So this might be a little biased, but essentially during the TPA, most hospitals, neurology is running this, so they're constantly doing neuro exams. They're looking for evidence of bleeding, so from the gums, even out of the ears, seeing if there's any sort of bleeding that way. They're checking the blood pressure because you have to keep it below 185 over 110, so they keep giving kind of as needed medications and watching that very closely. The other thing is if any of these warning signs happen, they discontinue and they get a CT if they can figure out what's going on. And also something that I learned is that there is a small risk of oropharyngeal angioedema, so swelling around the airway. When they have TPA and shortly after is a reaction that's been known to happen, so monitoring for that. And then after the TPA, it's just continually checking on them, the blood pressure, and then the follow-up CT that we hope to see, like the one I showed after the thrombectomy, where it shows that we do have reperfusion. So that was kind of all that's going on right now, and then I wanted to give a little kind of into the future. So the thought is that the stroke therapy will become TPA and thrombolytics, and hopefully thrombectomy will become so standard of care that they won't actually need to be automatically to the ICU. So a lot of places now, person had a stroke, they're automatically, everything triggers, they're going to the ICU no matter what. The thought is that these therapies are getting so much safer and kind of more standard practice, and we know what to do with them, that not every patient will need to automatically go to the ICU. So this study actually looked at if they could find certain predictors of those patients that would force that would need them to go to the ICU. So kind of using this scale, the ICAT scale, to see whether or not we should send them to the ICU, to see whether or not they have increased chances of airway compromise, unstable vitals, basically things that we would want them in an ICU for. And what they found from their study was that if they're a man, if they're a black race, they have high systolic blood pressure, and then you look at the severity of the stroke based on that scale I mentioned earlier, and using those factors, they actually found it's pretty predictive in the 90% of specificity and sensitivity whether or not a patient, after they get TPA, will need to go to the ICU or whether they can stay on the general floor. So obviously, patients don't have to be in the ICU. We love that bed. We love the bed to be open for people who really need the care. So that was just a glimpse of, I think, where things are going, and also, we're advancing the thrombectomies. But yeah, that was interesting. So yeah, that is my talk. If anyone has any questions, or if you want a copy of any of the resources or look at anything that I cited, just please let me know. I have them all saved. Print them out or give them. But what questions does anyone have on any of this?
Good job.
Thank you. We're looking, my research fellow is looking at Dr. Chris Kelly. Coming out here? Anybody got him, Chris?
Do you want a break and then do that, or?
Oh, you gotta keep going.
Okay.
You gotta stretch out to get some chocolate,